This week on the BackTable podcast.
I've had people do well with just PVA, and that's what we used to do for almost every one in the beginning. So PVA, I've used glue, I've used Onyx, I've used coils, I've used Onyx with Scepter Mini balloon catheters. In my series, I haven't found a big difference, but certainly that's just my personal experience. But we've had some good results with just PVA, and that PVA is, especially if it's a nice sized vessel and you go slow, you don't really slam it in there. Let the vessel take it like we would do for a liver or something like that. And I've had great results with that. I can get 3 vials, if you're patient. Sometimes if it's small and I want to get distal, or if I have a dangerous collateral, that meningeal ophthalmic, which is probably the one we see the most, and I want to be beyond it, I'll go with a smaller microcatheter and get, distal.
Welcome to the BackTable podcast. This is Michael Barraza, returning as your host. I'm joined today by Dr. Paul Gulotta at Ochsner. We're going to talk about middle meningeal artery embolization. Paul, thank you for joining us.
Glad to be here.
Paul, you are trained in both body and neuro IR, correct?
Yes.
Are you doing both in your practice?
I used to do pretty even, but I don't do body as much anymore. I'll go help the body guys out sometimes, but I would be doing a Y90 or something and a stroke would come in. So it just got really hard to schedule. So mainly neuro now. So
what is call like for you for neuro IR?
Our group is 2 radiologists, a neurosurgeon and a neurologist. So we're Q4. And we come in a good bit. It's certainly better than when it was Q3. So,
What else typically brings you in besides strokes?
Stroke's going to be the one that's we got to be able to get to the hospital in 30 minutes. So occasionally bleeds, we will do some aneurysms in the middle of the night, but usually those are a first case next day type of thing. So, but if there's some head and neck bleed or something like that, we'll come in the middle of the night. We're certainly happy to, but you don't want to stress, wear out your team or anything like that.
Absolutely.
So, but strokes keeps us, that 30 minute, if you think about timing it, you hop in the shower and then drive in, you're pretty much, at 30 minutes. So
I'm taking stroke call as well.
Yeah, right. I know.
Yeah, one of the big challenges for us, I think, are the transfer strokes. You hear about them. Ours, they communicate on the Rapid app, and then it's like, all right, we're coming from wherever, South Louisiana.
Right.
2 hours later, they arrive. It's like 3 a.m. Those are the ones that can ruin a weekend.
Totally. Those 3 a.m. ones are tough, especially if you're working the next day, and then you don't know whether to go home for an hour or just stay, So yeah, that'll keep you busy, but
For middle meningeal arteries, we're not doing those at night.
Nope. Occasionally we'll do them on the weekend, but we don't do those at night. So
yeah, I love them. I think they're a lot of fun. They're good cases. Paul, could you just start by maybe explaining the rationale behind why we're doing middle meningeal artery embolization?
Sure. So we're trying to treat chronic subdural hematomas. So some of the referring colleagues, it takes a little, educating. This isn't for an acute hemorrhage, chronic subdural, or a subdural hematomas that can happen with, the traditional mantra of like tearing of the bridging veins. That's not really what we're dealing with here. So what happens, there's some inciting event and there's a bleed, and then there's this sort of inflammatory cascade happens where you get this sort of neovascularity along the dura, and you get these new capillaries which are immature and they kind of leak, and then that causes continued bleeding, which causes more inflammation, which causes so that's why we think that the middle meningeal artery embolization is effective. It's just this new neovascularity along the dura that's producing this sort of, and a lot of times it's sort of, I don't know if it's serous or, but at least on CT, it looks hypodense,
What is the process like for, once a patient's in the ER, gets a CT, you got a chronic subdural hematoma, from there to on the table, like what are the steps?
So anybody who, we certainly evaluate them. Fortunately, we're very close with our neurosurgery colleagues, and we have a nice big critical care, and everybody has input into what's appropriate for the patient. Obviously, a patient that has significant mass effect or midline shift, they're still going to go to surgery. We'll evaluate the patient, see if it's appropriate. Occasionally we'll get requests for acute subdurals, which we've actually done them sometimes, but they haven't been totally effective because it's sort of a different pathology that we're kind of trying to treat there. So we'll see them, take into consideration the, clinical presentation if they're comatose or, and there's a lot of midline shift, those people are still going to get the traditional sort of method. A lot of times it can be hard to tease out how they are presenting. They can have headache, they can have cognitive decline, they can have, so it's not always going to be, like a shift type presentation, where they're really presenting with mass effect symptoms. So, and then we'll get a CT, we'll look at it, we'll kind of look at the history. Typically the inciting event can be a couple weeks ago,
Yeah.
It will review the medications, in general, this is an older population group. They're maybe on anticoagulants or antiplatelets. That's not going to stop us from doing the procedure, and then they'll probably go to the neuro ICU if they think that, it's kind of, they need close monitoring, or they would be admitted to the floor, and then we'll review, and then we'll try to get it done, within the next day.
Yeah. We've done the vast majority of ours in the inpatient setting. I have had a handful of outpatients. Are you guys doing any outpatients as well?
Yeah.
How are you guys managing those?
It's an interesting process. So, some of these patients are walkie-talkie doing fine, and you go home the same day, but the billing code is an intracranial embolization. Therefore, they have to be at least obsed in the hospital or as an inpatient for 24 hours in order
I learned that recently the hard way.
Totally. Yeah. And otherwise the patient may get a large bill or something like that. So we have been actually putting them in the neurocritical care afterwards, for 24 hours. I think they could perfectly be monitored a lot of times on the floor, but it's just been easier to kind of do that. And that's the process we do for our most interventions, aneurysm, carotid stenting, we'll put them in if they're elective, at least for 24 hours. So we found that to be easier.
Is there a role for doing these in the patients who have had an evacuation?
Yeah, certainly. Recurrence is certainly something we want to prevent. I don't have, I was trying to read up on some of the trials and all that, there's been a lot of literature out, but I don't have an exact number, but to prevent another surgery would be certainly a great thing for the patient. So we do that. Depending on the type of procedure, it kind of alters how I think about the case. If they went and had a big craniotomy, they may have sacrificed the middle meningeal artery, and you won't really be able to do too much there. Occasionally, they can collateralize from the other side, so we may embolize that, or you may only be able to get a little bit of your embolic material, even their coil in there, because the vessel's so small. So if certainly they're candidates if we can prevent them from getting another big surgery. So
yeah. Are you primarily doing unilateral, or do you occasionally do both sides?
We will go to the side that has it and then look and then go shoot the other side. And if there's any hint that there's some collateral, we'll do both sides. So
what are you looking for with that?
Just if it's crossing midline, on the contralateral side. Yeah, right. Yeah. So because it's tolerated pretty well, I mean, we'll do both sides a lot of times unless there's some other,
Yeah, I mean, we see the occasional patient who's got bilateral bleeds, and it's nice. Sometimes you get one of these patients who's got, pristine vasculature.
Sure.
And those are the ones where it's like a fun, kind of easy procedure. But, of course, we see some of the 90-year-old
arches. Type 3 arches, carotids, so we've certainly done them on nonagenarians. I don't know if I've ever done on somebody who's 100 years old, but we've certainly
gotten close.
I've done strokes on those patients, but
so have I.
Yeah.
I think that pretty much covers who's a candidate. Is there anything else, any other patients you look at, imaging or otherwise, is like, no, this is just not the right patient for this?
We certainly go through the workup. Some of the patients, and it sort of guides how I'm going to do the procedure. Oftentimes, some patients are too sick to get general anesthesia. We usually have anesthesia involved, but they may do a MAC or something like that, or a light sedation. So that's something I think about. I try to review any imaging they may have. I advocate, if we can, get some sort of neck imaging or chest imaging. A lot of patients have it already, so I try to look at that, and that's going to guide, but that's sort of, and we haven't had to eliminate, too many people. I will look at the head CT. There are certain collaterals, which we'll probably get into later, which you can almost predict based on the head CT that they may have a collateral that's not going to let them be a candidate. I still would probably go do an embolization.
Yeah, I look forward to hearing that, how you find it on the head CT.
It's rare, but if you have a recurrent meningeal coming off the ophthalmic, you go look at the foramen spinosum, And so you're supposed to have that footprint sign where the foramen ovale, and then, so if they don't have a foramen spinosum, you got to assume that the middle meningeal comes off somewhere else, right? So I don't think it's 100%. I'd still probably go, do the angio just in case, but I urge my fellows and residents to look at that, By the same token, that can be hypertrophied if you have somebody with a dural AV fistula or something. So you can go look at that foramen spinosum and kind of see what you're maybe getting into. So,
all right, well, let's talk about how you do them. You mentioned that you guys are usually doing them with anesthesia.
I've certainly done them with moderate, but yeah, that's my thought in the beginning. It's whether we want them intubated, and so when we first started, but now we usually try to get anesthesia involved, whether they want to MAC them or something. If you got somebody with bad sleep apnea, it's almost worse if you're in that gray zone, because they'll start breathing real hard, and that's where all that, the vascularity is there. So it's you either want them real light or full, so.
Right. What about in terms of access? Do you do femoral access?
We still are a femoral shop for a lot of things. I've gone to some people if I can look at their imaging and look at their arch and just say there's no way we're going to get there, I'll switch to radial, but we're still predominantly a femoral shop, so.
So are we. What do you go up with?
So that's a great question, and it all depends. So if I think it's going to be a straightforward, I'll actually just use my diagnostic catheter, Davis, and put something through there. If I think that either the arch is going to be tough, I'll probably go with a 6 French sheath and a benchmark and use a VTK or a SIM2. I like the VTK because you don't have to form it, SIM2. So, and that can usually get me up at least to the bifurcation. So I have run into, and I guess we talk about it later, I mean, the benchmark is, or some sort of 6 French guide is a little more expensive, but it's a little softer than some of the diagnostic catheters, so it may cause some less spasm, and you can do control runs around it, all that stuff. So
how far up do you try to get the benchmark ideally?
So I go do a common run. If they're fine, I'll do an internal run. If their bifurcation looks fine, to look for that choroidal blush make sure the ophthalmic, which is going to be probably your biggest trouble spot, comes off where it should, comes off the carotid like it should. And then I always urge my fellows, I say, you want the catheter to sit in the vessel the way it kind of naturally would want to sit. So right when that IMAX goes up is a really nice spot for it, so it kind of takes that nice curve. So if you have a Davis or a Berenstein, kind of position it there. The benchmark will go, it's pretty soft. It'll go pretty high up, almost to where the STA and the IMAX or middle meningeal split. You can put it up pretty high. So
what do you use for a microcatheter?
That depends on what I'm doing, right? So if I'm doing particles, I'll often use a True Select, which is a very
that's my go-to for these.
Yeah, from the body world, that was I love that catheter. If I'm doing, it's funny, I've played with every sort of iteration I can think of. If I'm doing real distal, I may use a headweight duo, or the Prowler makes, for the glue, they make that in 0165 or an 021. I've used, if I'm gonna, I've liked to try, and I know all these trials, and I wish somebody would just tell us what you're supposed to use, but
Thank you.
So please.
That makes me feel better because, I've been waiting for the right answer. Like, what is the best thing to use? And you ask around, you ask people what they use for embolics, and you get 3 or 4 different answers.
Sure.
And a lot of these answers are very confident, like this is what to use. And I don't know.
I've had people do well with just PVA. I've had people, and that's what we used to do for almost every one in the beginning. So PVA, I've used glue, I've used Onyx, I've used coils, I've used Onyx with Scepter Mini balloon catheters. I've used everything. In my series, I haven't found a big difference, but certainly that's just my personal experience. But we've had some good results with just PVA, and that PVA is, especially if it's a nice size vessel and you go slow, you don't really slam it in there. Let the vessel take it like we would do for a liver or something like that. And I've had great results with that. I can get 3 vials, if you're patient. Sometimes if it's small and I want to get distal, or if I have a dangerous collateral, that meningeal ophthalmic, which is probably the one we see the most, and I want to be beyond it, I'll go with a smaller microcatheter and get, distal.
So when you do that, are you going, when the middle meningeal splits, are you going into each individual branch and treating from there?
Yeah, sometimes I'll coil that meningeal ophthalmic branch. Yeah, it's not drop one coil in there and then you should be good to go.
You're probably pretty good.
Yeah. Ideally, if you can get in a wedge position where the bifurcation is far enough up between the frontal parietal and the squamous temporal branch, the anterior and the posterior branch, and you get a nice wedge, you can hit them both. But sometimes that bifurcation comes off a little too low that so I get worried about some of the liquid embolic getting back to the foramen spinosum and causing a problem there. So
let's talk about the collaterals that you look for, anything that you're looking for in an angio that's going to change how you approach these.
Yeah, so start the angio. If we don't see the ophthalmic coming off the ICA, then it's got to come off somewhere. If I go into the case and don't see the foramen spinosum, I'll see the middle meningeal come off that ophthalmic, and that's not going to be a patient that, unfortunately, we're probably not going to be able to treat. I will go and do a nice ECA run. Fortunately, we don't see there's a cavernous branch to the inferior lateral trunk. Occasionally, I really don't see that often. There's a petrous branch that I don't see that often. And if you're using particles, you're going to be too big to get into those branches. But the one that can really be a problem is that meningeal ophthalmic. And I've injected in a wedged position just because there was some spasm with the diagnostic catheter, and it was enough to reflux that branch all the way back to the ophthalmic, all the way back to the ICA. So obviously, we still treated that person, but we got way beyond that collateral. So those are the ones I'm looking for.
So I forgot to ask, when you're using particles, what size are you using?
When we first started, we did 250, 350 PVA. I usually do 150, 250 now. So I've heard that sometimes it can be tough getting through the foramen spinosum, but if I'm going to use the 150, 250, I try to get beyond the foramen spinosum, I've heard of there being some cranial nerve problems when you're there. I think it's probably low risk. Less likely, but still try to get beyond if I can. So, but we use 150, 250 pretty much. So,
and then what's your endpoint when you're injecting the particles for these?
Yeah, just that sluggish antegrade flow. And then I don't do a 5-beat stasis necessarily, but I just but I like to, teaching my fellows to get them to go slow, and just kind of let the vessel take it rather than, slamming it in there and occluding proximally. So,
yeah, I've been going really, really dilute, like diluting these to about 20 cc's.
We just get it out, the contour comes out. I think I do like an 18 contrast, 7 saline mix, and then we just mix it in, which is 25, and just try to get that in. Just make sure, your hub, the PVA wants to kind of clump in the hub, just kind of be careful, so. But I think that's been tolerated pretty well. We obviously don't want to reflux, but the next branch down is the IMAX, which is what we hit for nosebleeds. So if you got, obviously that's not ideal, but if there's a pop-off valve before something important, then you're probably okay.
What about for glue? How are you doing the glue? Like what ratio?
Usually 4-to-1, occasionally 5-to-1. I've had some where, you kind of really get a nice embolization of the anterior and you pull down and you want it to hit the posterior. And it does some, but, and if you can get a nice wedge position, sometimes you can get both from one spot. So,
okay. What about if you're coiling it? Where do you try to coil?
Can we talk about, obviously we've been talking about companies, but Penumbra has they have
the liquid metal or whatever. What's it called?
It's the pack. It's like their packs, but smaller, and it's supposed to behave like Onyx. So that I'll go way far out and just let it kind of come back and take whatever it takes, so. If you're doing that, I've run into trouble. I would get yourself a little more support than just the Davis. I would get it up closer. What's really nice, I don't know if you use the benchmark much, but what's really nice about the benchmark is not that if you're doing this case, but if you're doing another case and you want some more distal support, you can put the 5 French Sophia in the benchmark, which would give you a triaxial system. I don't think you necessarily need it, but I would. If you're doing the coils and getting real distal, I would probably have a little more support than just a Davis. Yeah. So they're fun. You want to just choose the right size. Obviously you don't want to be cost prohibitive and just put a bunch of coils up there, but, you kind of play with it at first, see how it feels, because they come in like 5s, 15s. You're not going to want to throw a 45 up there if you don't know how it's going to behave. So
All right. So you finish your embolization. What happens next?
So as far as, what's next for the patient or just like the case or...
Yeah, you do another run, you finish your embolization, close it. What about for the patient? What happens next?
Hopefully, if the patient came in and doing well, they're still doing well. Obviously, we try and get a really good neuro exam, including, I try to do a neuro exam on the table if they're under moderate sedation. If they're gut general, then we would try to do it in PACU or whatever, or go up and see them in the ICU. But fortunately, knock on wood, most of the patients, I'm not supposed to do that because of the microphone, but fortunately, most of the patients do well, and don't have an issue. But I like to get a good neuro exam. And then depending if they came in electively, they could go home right then, but they usually stay for 24 hours.
Right,
so.
Stay for the night.
Yeah.
Go home the next day. Do you get any follow-up imaging on these patients?
So a lot of that is guided by our neurosurgery colleagues, and they see the PAs. I was reading today about some protocols. Some people do 1 month, 3 months, 6 months. Sometimes they'll get a CT right away afterwards, which I don't know if they're just trying to establish a baseline, but I'm not 100% sure that's that beneficial if you had one right before. Interestingly enough, if you get the CT within 24 hours, a lot of the subdural, it'll look like they bled again because it enhances. Yeah.
So I had one an outpatient actually, and I went to see her like right after the case, and she got pretty heavily sedated and she looked pretty bad. And so we scanned her. Her bleed was like a good bit larger, but you could see all the hyperdensity, but it was clearly contrast. It wasn't acute blood.
But so that can be a little tricky and a little scary for your diagnostic colleagues to. Fortunately, we've done quite a bit of them and we've come to recognize it now, but yeah.
That's about all I got. Paul, is there anything else about this procedure that you think it's important to talk about?
I kind of wanted to go, I was thinking about what we talked about, the sedation. A lot of these can be done with moderate, but some of the liquid embolics are painful. The DMSO is painful. The glue can be painful. So those people you probably want to use anesthesia with. If your nurse is sedating, you're doing moderate, you don't want to go too much right in, especially if they have sleep apnea or anything like that, so because that's really the area that you want to focus on. I'm trying to think of anything. I think until somebody tells us what to do, I think picking something that works for you, that can be done safely, and you can reproduce it, your team's comfortable with it, If doing liquid embolic is like a whole operation and people aren't used to it, then, they could get used to it, but, it's just, you want to make sure your team and, if they come and say, it's clearly better to use liquid embolic, then we'll all have to switch. But I can, I did one with my fellow not too long ago, particles bilateral, and we did it in 43 minutes, and it probably the particles cost a couple $100, catheters cost a couple $100. Whereas if, I've also done it with Onyx, bilateral scepter minis, benchmarks. You're looking, so is the juice worth the squeeze on the price there? If we're talking about for a hospital system, we got 85% efficacy or 89% is the money, worth that? I don't know. We'll see. I think that'll bear out in the future, what's going to be the best. And, so.
I hope so.
Yeah, at least for guys like us, we'll be able to figure out, what's the best thing to do. So
I hope they continue telling us it works because I really enjoy these.
Yeah, no, they're great procedures. It's ECA. So as long as you're comfortable with the anatomy and you've done it, a few, then I think it's, it's fine. I think ECA branches can be a little confusing on the lateral. STA kind of also goes in that, but if you have the AP, you can clearly, the MMA has that characteristic turn as it goes through the foramen spinosum along the greater wing of the sphenoid. So usually can tease that out. Like you said, it's a fun procedure. At least for now, it's a well reimbursed procedure for, it is a 6164 if you do it bilaterally. That's not why we do it, but it's
but it helps.
Yeah, sure. So.
All right. Well, thank you for sharing your time and your expertise.
Yeah, it was great. This was a lot of fun. So thanks for inviting me.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond, and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrizio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.